Minister.
Jolly good. Thank you, Mr. Bone. Pleasure to see you in the chair. Let me add my congratulations to my humble friend from North East Derbyshire for securing the debate. I know as Vice Chair of the All-Party Group that this is something that means a great deal to him, and we heard a little bit more from him today as to why it means a lot to him. So let me just place that on record, and thanks to the All-Party Group and the excellent ovarian cancer charities, which Target are, of course, the biggest, but there are others who work in this space, Overcome, etc., and their tireless work. Watching my humble friend from North East Derbyshire brought back memories. I remember sitting in that exact chair as one of the vice chairs of the All-Party Group on ovarian cancer in 2011, October 2011. This is almost exactly 7 years ago, talking about ovarian cancer, which has impacted my family, not with the outcome that the honourable gentleman currently has, I'm sad to say, and describing it as a silent national scandal, which even in 2011 was trending, Mr. Bone, which was quite something in 2011. And I was also here in 2014 in the debate that he remembers, which indeed was the last time this subject was debated specifically in the House. So it's a pleasure to hear him today. He reminded me of me. This is where you end up. I placed that warning on record. I was also very pleased to meet, as my shadow said, with the lady from Washington and Sunderland West and Target. It was a pleasure to meet with them a couple of weeks ago to discuss the All-Party Group report, which I have here. She knows that I take these all-party groups very seriously. I have this is my coffee table copy in the Department of Health. Anybody who knows in my office knows that what's on the coffee table is what counts. And I think it's an excellent piece of work, and I'll refer to it a lot during my remarks. There's a lot of very important recommendations in there. I've already committed to responding fully to it, and she knows that I will do that. So, Mr. Bone, I'm actually responding to my third cancer debate in less than 2 weeks in the House, which I think demonstrates what our priority improving cancer diagnosis and treatment is for honourable and right honourable members, as it is for me as the Cancer Minister and this government and the Prime Minister, and I know the opposition too. And I'm very fortunate in this job to see firsthand the superb work that is done by our staff in the NHS and by our many partners across the cancer community, the charities, of course, in implementing the 96 recommendations of the cancer strategy for England. We're 3 years into this work, and cancer survival rates, as has been said, have never been higher. Around 7,000 people are alive today who wouldn't have had mortality rates staying the same as before. CRUK and Harpel, who led the work, published the strategy. But as I make absolutely clear every time I respond to one of these debates, Mr. Bone, I know that we must do more. I know that people want us to do more because we lose 12,000 women a year to breast cancer still. We lose far too many women to ovarian cancer still, and we know we must do better. So despite the huge strides that I've mentioned that we've made and the best ever survival rates, ovarian cancer survival rates in the UK are among the lowest in Europe, with fewer than half of all women diagnosed surviving for the 5 years or more. So there is much that we need to do. So that's why, yep.
I thank my honourable friend for his way. He has just mentioned the success rates in dealing with cases of ovarian cancer in our country compared to some of our European partners. Can he set out what he thinks we might be able to learn from some of our European partners in terms of improving outcomes for women in this country?
I will certainly cover that for my honourable friend and for members. But put bluntly, which I will come on to in just a second, and which almost everybody has mentioned, it's detecting them early. And that impact is early diagnosis, as the former chair of the All-Party Group on Cancer has said many times, early diagnosis is cancer's magic key. And we have that magic key in some cancers in this country. We do very well in breast, where the early stage survival rates are well over the 75% target that the Prime Minister set out at party conference earlier this month. But we don't yet have that magic key in enough cancers, is the truth. And that's what I'm hopefully going to come on to now, which is what we need to do. So I was really pleased when the Prime Minister made the ambitious package of measures announcement earlier this month for cancer care and treatment, and that will be at the heart of our long-term plan for the NHS, backed up by the new funding that was announced in the summer and confirmed in the budget yesterday. We will overhaul screening programmes, provide new investment in state-of-the-art technology to boost our research and our innovation capability, and then, as I say, critically transform how we diagnose cancers earlier. So the ambition, as I've said, is that we will diagnose 75% of all cancers at an early stage, with 55,000 people we estimate surviving cancer for 5 years in England each year from 2028 as a result of that ambition. Now, as I said, all members have mentioned early diagnosis, and many have mentioned some stats and the same stats. But the one for me is that a quarter of women with ovarian cancer are diagnosed through an emergency presentation. When I was first an MP, Mr. Bone, I remember going to meetings with this group, with the all-party group for cancer, and being shown the stats for my constituency on the number of people who present in the emergency department with cancer. It really frightened me, and it really shocked me, and it was one of the reasons, and my personal history, that I wanted to get involved in health and cancer when I joined the House. And it's one of the things that still shocks me. So just say that again, a quarter of women with ovarian cancer are diagnosed through an emergency presentation. And of these, just 45% survive a year or more. This is no surprise. And of course, if you're diagnosed in the emergency department, you have therefore exhibited more outward symptoms, therefore you are at later stage, therefore your survival is later. So survival is over 80% when women are diagnosed following a GP referral. So it's crystal clear to us where improvements are urgently required. And that's why early diagnosis is one of the key strategic priorities in the cancer strategy. It allows for far more options for treatment, as has been said, and crucially, the earlier the cancer is then diagnosed, the more likely it is doctors will be able to provide successful treatment or be able to operate on the bunch of grapes, which I think is a very good analogy and one I've heard before. Now, my humble friend from North East Derbyshire in opening the debate talked about MDCs, the multi-diagnostic centres, and that is, NHS England and we are testing new innovative ways of diagnosing cancer earlier. So the ACE centres, as we call them, Accelerate, Coordinate, Evaluate, snappy title. And regular attendees to cancer debates will know that I never tire of praising them. They are the multidisciplinary diagnostic centres for patients with vague or non-specific symptoms, and they're currently being piloted, as the lady opposite said, across 10 sites in the country. They offer patients a range of tests on the same day, which is a point that has been made by a number of members, with rapid access to results. Now, they are magnificent. I visited the ACE Centre at the Churchill in Oxford earlier this year. I met the practitioners working in the centre. I met the commissioning group. I met the GPs that are involved in it. The GPs especially, coming back to that point, are tremendously and right to be excited about the ACE centres. We think they will make a huge step change improvement in early diagnosis, particularly for cancers like ovarian, where the symptoms can be vague, where they can appear less serious at first. And the plan is for this innovation to address the delay that my shadow opposite and other members spoke about. So instead of the GP having to refer for one test, waiting for results, referring to the next test, waiting for appointment, waiting for results, this is the whole point of the ACE centres, that it is a snappy, quicker turnaround. And I think that that can be a game changer, and I think that could unearth the magic key when it comes to ovarian. Now, the all-party group's report says that we should roll them out nationwide, so I'm delighted, as I know is the lady from Washington and Sunderland West, the Prime Minister recently committed to doing just that as part of our long-term plan. I don't get easily excited, Mr. Bone, as you well know, but I am excited about the ACE centres, and I think their potential could be transformative. I want to touch also now on early diagnosis in primary care. So There are other support measures necessary, we think, to ensure that more cancers are caught in primary care. So the NICE guidelines for suspected cancer referral recommend safety netting for those at the higher risk of cancer but who do not meet the referral criteria. Both CRUK and Macmillan have produced additional advice and support for general practitioners in implementing these guidelines, including this safety netting that I mentioned over the last few years. Macmillan GPs, who I was blown away to meet at Britain Against Cancer earlier this year, I think are an excellent innovation. And I think they have an awful lot to give, but they are small in number. And I'm very interested and do talk to Macmillan about the potential of Macmillan GPs in helping transfer that knowledge, that specialist knowledge, to the wider general practitioners. And I always say this about GPs, Mr. Bone, is that it's not dissimilar to MPs holding our surgery. Almost everybody who comes to our surgery is more of an expert on the subject they've come than we are, because we are general practitioners. And so GPs get a hard rap, but they are general practitioners, and that is the profession that they've chosen to go into, which is why we need to support them better through diagnosing cancer from our targeted lung cancer screening in the car park, in the lorries in the northwest, where we've trialled that in Manchester, which has been very successful, to the ACE centres that I've mentioned. And that's all aimed at supporting the NHS, especially GPs, to identify cancer earlier. The lady speaking from the shadow front bench talked about reviewing the referral pathway and asked about that question. So the implementation, as she knows, of the faster diagnosis standard. So that requires trust to review and speed up diagnosis pathways for suspected cancers. NHS England and NHS Improvement are working closely together to emphasise the key principles for improvement that we need here, which includes ensuring the most value is derived from each appointment. So the standard is being measured from April 2019 to next April, a year before it comes into place in April 2020. It will ensure that patients are told they have a cancer diagnosis or an all clear within a maximum of 28 days of being referred urgently by their GP for suspected cancer. And as I always say, 28 days is not a target, 28 days is a maximum. 28 minutes can seem like a lifetime when you have a cancer worry. And it always seems to come on a Friday night when you've got the weekend ahead. So 28 days is our new target, but it is certainly not what we aim for. We aim to do better. Now, we've heard from a number of members, including the member for Strangford and the lady for the opposition, about Be Clear on Cancer. Be Clear on Cancer is one of the great successes of public policy in recent years. The All-Party Group's report also recommends, as the lady said, running a Be Clear on Cancer campaign to raise public awareness of ovarian cancer symptoms. But she, of course, is experienced in this and smart enough in this business to know that Be Clear on Cancer doesn't, and certainly in this cancer, cannot focus specifically on a cancer type. It is about clusters. And that's where we found it to be most successful, actually. So PHE, Public Health England, for whom I have ministerial responsibility, take a number of factors into account when deciding which campaigns to develop. There is, of course, healthy competition in this space, and there is always more demand than supply, unfortunately. And then the ones that we run with one of the main criteria being the scope to save lives through early diagnosis. That is what I judge it against. Now, the campaigns can only be effective if a cancer has a clear early sign or symptom that the general public can act upon should it arise. That, being blunt and being honest, is part of the challenge here, as already said, for the reasons already said. So the regional Be Clear on Cancer pilot for ovarian took place in the northwest of England in February and March 2014. So a while ago now, with the simple key message, feeling bloated most days for 3 weeks or more could be a sign of ovarian cancer, tell your doctor. The PHE is currently undertaking new data analysis and research to determine Be Clear on Cancer campaigns for next year, so that's 1920. No decisions have been taken at this time, and I take the bid from today very strongly. So the outcomes from the regional pilot, and a pilot which focused on a range of abdominal symptoms, which is where I think we would head with this, such as diarrhea, bloating and discomfort that can be indicative of a number of cancers, including ovarian, will be taken, of course, into strong consideration. But let me be clear, PHE and NHS England have a very clear steer from me that I want to run the campaign on abdominal symptoms, low abdominal symptoms, as soon as practically possible. We've got to make sure that the operational capability is in place across the NHS, because the worst thing that we could do would be to create a demand and not be able to meet it. I think that is a rather boring practical reality, but it is a reality. But I've reiterated this to the all-party group recently when we've met, and I will, of course, keep members updated. I know they follow these matters very closely. The member for Strangford also asked about genetic testing and its role in identifying the increased risk of ovarian cancer. So one area where England is very much at the cutting edge of cancer diagnosis is through the creation of the new National Genomic Testing Network, delivered through 7 new genomic labs, hubs as we call them. This will give patients access to state-of-the-art tests that can diagnose their disease or help inform their treatment. So the genomic lab hubs will do 3 things. 1, provide consistent and equitable access to genomic tests, very important, so there's a level playing field. 2, operate to common national standards, specifications and the protocols. And 3, deliver the single national genomic testing directory, covering the use of all the genomic technology from the single gene to the whole genome sequencing for cancer and rare inherited disease. So they're currently in a period, the labs are currently in a period of transition to fully embed the new infrastructure and the new National Genomic Test Directory, and this transition will ensure, I hope, the safe rollout of the service without disrupting current clinical care. Patients will continue to receive the testing they need to inform their clinical care, and the new National Test Directory will also include the BRCA testing for women with ovarian cancer, in line with the NICE guidance, which he rightly mentioned. Now, while we're on the member for Strangford, the member for Westminster Hall, as I like to call him, he also touched on screening programme, and as did the lady for the opposition and the member introduced in the debate. So the UK National Screening Committee is awaiting the updated results of the UK trial of ovarian screening, the UK CTOCS, as it is known. The Secretariat is in contact with the researchers, and the committee will review the findings as soon as they are published. He's absolutely right to talk about workforce, and the all-party group report on page 8 of its report talks about the importance of sonographers. So the increased emphasis on diagnosing cancers earlier, we will not be able to find the magic key without those that do the searching, and that is our NHS workforce. So we must ensure that we have the right workforce in the right place to deliver that frontline care and meet the Prime Minister's ambition. So last December, Health Education England published their first ever cancer workforce plan, committing to the expansion of capacity and skills. HEE will follow that plan up with a longer-term strategy aligned with the NHS long-term plan, which seems like sensible to me, and that will look at workforce needs beyond 2021. We have to look very long landscape when it comes to NHS workforce. Now, I won't preempt the plan, but I can absolutely assure honourable members that it will set out how we will ensure sustainable cancer workforce is in place to deliver on the ambitions that we've set out. Now, the member for North East Derbyshire, Mr Bone, talked about the cancer dashboard, and the all-party group report, which of course he was involved in drafting, also recommends including ovarian cancer data within the dashboard. So the dashboard was first published in May 2016 as a tool to help the cancer alliances, the commissioners and the providers in the acute trusts to quickly and easily identify the priority areas for improvement and to enable easy tracking of progress towards our national ambitions. So Public Health England is working with NHS England's cancer programme team on the next phase of the dashboard development. This will be informed by the needs of the key stakeholders and the cancer charities, with whom I hold a regular roundtable. Some of them are here in the gallery today. Honourable members, it is no secret, Mr Bone, know that I am frustrated about the dashboard. I am impatient about most things, as my private office will attest, sadly, and I am incredibly impatient about the dashboard being limited to the top 4 cancers. I want to see it expanded. I intend to see it expanded, and NHS England and Public Health England have a very clear direction from me that I'm watching their work, and I expect to see it produce what I want and what members in this House want. The lady from Sunderland and Washington spoke about surgery and the mixed picture about surgery around the country. I don't have the detailed answer. I don't want to to shortchange her by not giving her the detailed answer that I want now. But I will take a look into the point that she raised. I think it's a good point, and I will write to her and other members that are in or have been in the debate today on the point of surgery, because obviously we've got to diagnose early, and that gives us better treatment options, less radical treatment options. But for some, obviously surgery is there as a sad reality, and we've got to make sure that the NHS is not only good at sharing best practice, but it's good at implementing best practice, and that is true in surgery as anywhere else. So in closing, Mr. Bone, I just want to pay tribute to the hard work and the professionalism of our dedicated cancer workforce and members who care so passionately about this subject and have brought it to the House today. Ultimately, it is our workforce that will determine the success of the cancer strategy and the long-term plan for the NHS. We can only set the direction, set the ambition, and make sure that the resources are in place. And I believe that as Cancer Minister, I'm doing that. I am excited by the huge potential for the next 10 years on cancer diagnosis, treatment and support. We have fully established the 19 cancer alliances, and we back them with the funding that they need to transform services, and we'll go on doing that. We will continue to back them to ensure that the NHS long-term plan can be delivered on the ground through the alliances with cancer at its heart. And I think that plan can turbocharge all that we've achieved through the cancer strategy. But I have said before, and I'll say again, I want the cancer alliances to be much more open, to be much more accountable, and to be much more approachable by especially members of Parliament in England, who should be able to call them into account much more than they do. And I suspect many members in this hall today have got the chief executive of their local trust on speed dial. I hazard a guess that they don't have the leader of their cancer alliance as the same, and that should change. Let me just also briefly say before I close on my humble friend from Berwickshire and Roxburgh. It was very interesting to get the Scottish perspective on this. We would like to see the ambition in England, of course, matched across the whole of the United Kingdom. And we absolutely stand ready, as always, to work with Scottish members and to work with the Scottish Government. If there's anything that we can do to help share that ambition, then we will, of course, do it. So NHS England and I, Mr Bone, and Public Health England, with the tireless support of our cancer community, Team Cancer, as I always call it, are committed to making the ambitions that the Prime Minister set out a reality. This will ensure, as I said in this place not 2 weeks ago, and I will say it again, that we continue to make huge leaps forward over the next 10 years to a future where cancer has no future. Thank you.